Have you ever been invited to describe your pet project in 10 minutes to a group of people and easily could have filled up half an hour because this project has been your baby for the past year and like all proud parents, you just can't stop gushing over it? Marketing and communication experts know that well-crafted and memorable health communication messages are brief, high impact, and visual. Research shows that the average attention span of an adult is as little as 8 seconds. Most information transmitted to the brain is visual, and images are processed several thousand times faster by the brain than text. My medical training reinforced this concept, and I was taught to let patients leave medical visits with no more than a couple of key messages, and to use visual aids to reinforce messages whenever possible. Unfortunately, this body of evidence has not translated into health professions education with much consistency. Slide presentations too often have too much information, minuscule fonts, distracting clip art, and are used as a script instead of as a visual aid. I am here to tell you that there is light at the end of the tunnel. Pechakucha, Japanese for chit-chat, is a presentation style that attempts to avoid the common condition of death by PowerPoint. Use this fast-paced format to communicate your content more efficiently and concisely. Essentially, you present 20 image-based slides for 20 seconds each, for a total time of 6 minutes and 40 seconds. Change agents and improvers are passionate about their work and love talking about it. Slides in Pechakucha style presentations run on automatic. This forcing function ensures that speakers end up with compact presentations, whether they like it or not. Pechakucha works best when the majority of your slides are images. Improvers in healthcare frequently present their work to eclectic and diverse audiences, and they have no dearth of visual materials, striking graphics, and poignant patient stories to demonstrate their point. Pechakucha was invented in Tokyo in 2003. Two architects, Astrid Kling and Mark Ditham, held the first ever Pechakucha night in their gallery and lounge Super Deluxe, as a way of getting creative people together in an informal and fun way to share their work and their ideas. Pechakucha nights have now gone viral globally and have been held in more than 1,000 cities around the world. Let me now use one of our quality improvement projects to illustrate how our work can be presented in 6 minutes and 40 seconds, using the 20 slides in 20 seconds format. Our pediatric residents and faculty physicians recently collaborated on a project to demonstrate that clinical care, graduate medical education, and continuing professional development can be simultaneously improved through quality improvement or QI efforts. I am honored to represent my team to share our work with you. Communication deficits between clinicians at hospital discharge are common and contribute to poor care coordination, adverse events, unplanned readmissions, decreased patient satisfaction, and high costs of care. Clear, comprehensive, but concise, timely, and accurate discharge summaries are an important communication tool during care transitions. At teaching hospitals, discharge summaries are commonly written by residents. However, residents frequently receive variable or little formal training in this skill. The Accreditation Council for Graduate Medical Education requires that residents be involved in QI activities. The American Board of Medical Specialties has similar requirements for physicians in practice. In a survey by the Value and Inpatient Pediatrics Network, most hospitalists said that they reliably send discharge information and that it contains all elements needed by primary care physicians. Although 3/4 of primary care physicians said that they did receive discharge information quickly, the content on summaries was often suboptimal and incomplete. Discharge summaries often lack key components such as hospital course, discharge medications, completed test results, pending test results, and follow-up plans. An additional problem is that many summaries, even those that lack critical pieces of information, are narrative and too long to be useful in busy outpatient settings. This project was completed by residents, attending physicians, and staff at the University of California, Davis Children's Hospital. We have a pediatric residency program with 36 trainees, and our aim was to improve the timeliness and quality of discharge summaries written on our ward by 10% over baseline over one academic year. Our interprofessional team included inpatient and outpatient pediatric attending physicians, nurses, discharge planners, a parent advocate, a QI analyst, an electronic health record analyst, 2 pediatric interns, and 4 pediatric second and third year residents. We analyzed discharge summaries for the index admission for children readmitted within 30 days of discharge. We evaluated a sample of 10 summaries per month using a summary scoring instrument based on our identification of best practices. The electronic health record was used to assess the timeliness of completion of discharge summaries. During monthly 1-hour team-based sessions, we learned QI methods, identified best practices, planned interventions, reviewed discharge summaries, provided peer feedback, and designed a standardized electronic health record template. The American Board of Pediatrics allowed us to provide maintenance of both certification credits to participating physicians. Our residents and attending physicians worked together to map our process for writing and reviewing discharge summaries. This process of mapping our workflow helped identify delays and redundancies. For example, we identified the residents wrote both a progress note and a discharge summary on the day of discharge. This resulted in redundant work and waste of time and effort. We completed a cause and effect diagram identifying factors that contributed to suboptimal quality and timeliness of summaries. The root cause of poor summary quality was lack of standardization of content. The root cause affecting timeliness was time expended in excessive and sometimes redundant documentation. Our scoring instrument assessed for key elements such as hospital course, discharge diagnosis, significant findings, procedures and treatments, discharge medications, pending labs or test results, patient and family instructions, condition at discharge, follow-up appointments, primary care provider's name, and appropriate detail and length of the discharge summary. This run chart shows how the quality and timeliness of our summaries improved over the 1-year period. The most effective interventions were standardizing content of summaries and a change in policy that if a summary was completed within 24 hours of discharge, residents would no longer need to complete a separate progress note for the patient that day. At baseline, elements of summaries most likely to be included were reason for hospitalization, procedures and treatments, attending physician's signature, and discharge diagnosis. Elements that were most likely to be deficient were summary of hospital course, appropriate detail and length of summary, significant findings and test results, and follow-up appointments made. Discharge summary scores improved significantly over 1 year. The percentage of summaries that included all key elements increased from 2% at baseline, shown by the first blue bar, to 80% at the end of the project, shown by the first gold bar. The proportion of summaries scored as being of appropriate detail and length increased from 5 to 80%. All key elements that had the greatest room for improvement at baseline showed marked improvements at the end of the project. Documentation of the hospital course increased from 10 to 100%, documentation of significant findings and test results from 30 to 100%, and follow-up appointments made from 30 to 100%. Monthly electronic health record queries showed a significant increase in the timeliness of completion of discharge summaries. The proportion of summaries completed by residents and reviewed and signed by attending pediatricians within 24 hours of discharge increased from 38% at baseline to 73% at the end of the project year. 9 attending pediatricians received maintenance of both certification credits. They actively participated in learning sessions, developed QI resources and tools, and reviewed and provided feedback to residents on their discharge summaries. Attendance at QI sessions was comparable to attendance at educational sessions on other topics and was sustained throughout the year. Engaging frontline clinicians in identifying opportunities for improvements and spearheading QI efforts can lead to clinically meaningful change. The most productive aspects of our intervention were standardizing the content of discharge summaries, using peer and faculty audit and feedback, and reducing redundancies by changing documentation policies. In conclusion, we markedly improved written communication at hospital discharge by integrating our clinical QI goals with graduate education and continuing professional development needs. We believe that adapting this intervention to other clinical training programs is feasible and likely to result in similar positive effects. Thank you. Mark Twain, in his inimitable style, said, "I didn't have the time to write a short letter, so I wrote a long one." Simplicity and brevity is hard. preparing for a Pechakucha presentation format frequently takes much more work compared to a traditional presentation. But I guarantee that your 6-minute, 40 seconds of fame will get your point across in a high impact, concise, and fast-paced way.